I think we are live now. A very good evening to all the students who are joining this session on YouTube and from other places. Just let me know if I'm audible and visible. So then we will start with the session. I think we are not live yet. Hello, Doc. Hello, Tarun. Hello, Kamalkant. Hello, 𝗬𝗚𝗧𝘂𝗧𝘂. I hope everyone is doing fine. Yes. Good evening, Yashwant. Good evening, everyone. Yes, so we are live. So a very good evening to all the students who are listening to this session here. This is a doubt solving session related to pediatrics. So if you are targeting a competitive exam like FMG, like NEET PG, 𝗗𝗍𝗫𝗃, or any other exam for that matter, you're most welcome to ask about any doubts if you are having right now. Good evening, Tarun. Good evening, Richa. Good evening, Aladi Vinay, Kashyap Nilesh, Hari, Rahul Saha, Sai Alekhya, Abhijit. See, I have things to discuss with you, but again, it would be better because it is a doubt solving session that you people start shooting doubts at me and we can take it on from there. Good evening, Nana Pot. So, my dear friends, where do you want me to start? I have a few points in my mind, the controversial things, the updates, which I wanted to discuss with all of you because NEET PG exam is just a few weeks away. FMG exam is just a few weeks away, and then INI-CET obviously in November, but still the preparation must be going fine. Okay. Yashwant Reddy is asking, must revise topics before exam, sir. Ayush is asking, please discuss the DK management. DK management is a huge topic, but since you asked me, I will be summarizing it. So must revise topics before the exam. So I will be writing here and the screen will be visible to all of you. So must revise topics. Must revise topics in pediatrics for the upcoming competitive exams. First of all, milestones are very important. You may get a question, you may not get a question, but if the question comes, it is always a rank deciding question. Second, neonatal resuscitation program. So neonatal resuscitation is a must-read topic. Thirdly, anthropometric indices. Indices of malnutrition. When I say indices of malnutrition, I mean weight for age, weight for height, and height for age. Not only their advantages, disadvantages, but also applied MCQs. If you look at past MCQs of NEET PG and INI-CET, you will find questions where a graph has been shown, and then based upon the graph, you have to plot and make the diagnosis in the patient. This has been asked in the exam. Then obviously severe acute malnutrition is important. Do not spend too much time reading about the unnecessary details which are mentioned in textbooks. But what is SAM? What are the two types? What are the complications? And what are the principles of management? And then the nutritional rehabilitation phenomena in SAM is something that you must revise. Then we have diarrhea management, the diarrhea classification according to IMNCI and its management, pneumonia classification according to IMNCI and its management. Remember that in pneumonia, you need to remember the latest one. Presence of tachypnea or chest indrawing is pneumonia. Any danger sign if added, then it is severe pneumonia. So this is a small thing which people keep getting confused and keep marking wrong in the exam. If you have seen the recent papers, cystic fibrosis is a very important topic. Also, examiners are fond of asking certain conditions like tetralogy of Fallot, TGA, and 𝗘𝗵𝗶𝗃. They are important. Then you have topics like pediatric epilepsies, which includes West syndrome, absence seizure, as well as juvenile myoclonic epilepsy. You have febrile seizure. There was a fresh question on febrile seizure in the recent INICET exam as well. And people said, sir, the revision session you had taken, it had been covered there. So there is a YouTube revision session on the DocTutorials channel. Please go through it. And if you have not done the topic yet, add it to your notes. If you are a DocTutorials subscriber, I have discussed the topic in details in my video. Apart from that, neurocutaneous syndromes are important. You have the fever with rash, DD is important. DD means measles, chickenpox, rubella, how you are going to distinguish. Congenital infections are very important. Then UTI in children is important. Then you have status epilepticus in children and its management. That is important. Meningitis, cerebral palsy, HIV infant feeding guidelines because they are updated. So the latest guidelines you need to know. They have changed significantly from the last few years. And then obviously the vaccines, the immunology, that is important. So these are the must revise topics. That doesn't mean the other topics are less important. But if I am targeting the competitive exam, I will make sure that these topics I do properly. Particularly if you are a FMG aspirant, for FMG students, micronutrient deficiencies as well as inborn error of metabolism will give another 3 to 4 additional MCQs, right? These topics are sometimes asked in the other competitive exam, but FMG में बहुत frequently आते हैं. And in addition, NEET PG people are very fond of asking questions on, asking questions on glycogen storage disorders. They are very fond of asking questions on glycogen storage disorders. So these you need to do in addition. I hope this is covering all the key points, all the key topics. This is a bare minimum list. This is not the maximum list, but the bare minimum list that you need to know. Apart from that, there are some overlapping topics like croup, laryngotracheobronchitis versus acute epiglottitis, laryngomalacia, topics which are overlapping with ENT. Then nephrotic syndrome and nephritic syndrome overlapping with pathology and medicine. These are the topics also which are frequently asked in the exam. So I'm writing in addition so that you don't miss that nephrotic versus nephritic, as well as croup, epiglottitis, and laryngomalacia. So these are the topics you have to go through in details from the exam, right? So first common query, which many of you have asked, I have covered it here. Second, Rahul Saha is asking epilepsy wala topic ek baar review kar dijiye. Rahul, you are asking me to do a tricky thing, but I will try my best to do it. See, let us first take the simple one. Ramji Pandya Rajan is asking, what is the screening and confirmatory test for cystic fibrosis? So let us start with the doubt solving session here. If we are talking about cystic fibrosis, it is a doubt solving session. So I will be very brief and talking only what is relevant to you. So if the question says screening test of choice, the screening test of choice is always sweat chloride test. Sweat chloride test. And what is the cutoff? If you find that it is equal to or more than 60 milliequivalents per liter of chloride, then it is considered to be a positive screening test for cystic fibrosis. But there is a problem. Sweat chloride test can only be done beyond infancy. Young newborns do not sweat properly, and sweat collection is a problem in that. So if MCQ asks you, what is the screening test in neonates for cystic fibrosis? If there is a strong family history and you want to diagnose the child in the first month of life, what test you will perform? Here you will do a blood test, very, very important. There is a blood test known as blood for IRT. IRT stands for immunoreactive trypsinogen assay. Immunoreactive trypsinogen assay. Cricket lover is asking latest GINA guidelines. Bhai, GINA guidelines, asthma ki ya CAH ka discussion. These are topics which will need 40 to 45 minutes. So it is a doubt solving session, not a theory session. Some key points I will be covering, but again you need to understand this is a doubt solving session. जो doubt आ रहे हैं mind में उसके लिए session है. So we will be very brief in the things that we discuss. And if the question says what is the investigation of choice or gold standard investigation in cystic fibrosis, it will always be mutation or gene analysis. If the question says what is the most accurate test, in bracket you would write not available easily. I have never seen somebody perform this test because it is only available in research centers. The most accurate test for cystic fibrosis is nasal potential difference measurement. Nasal potential difference measurement. I hope now you will not have any doubts related to the investigation of cystic fibrosis. Okay, so these are the key points you need to remember regarding cystic fibrosis. So this is the point. So take a screenshot of this if you need to remember for the future exams. Let us move further. Another doubt someone has asked me. Epilepsy वाला topic एक बार review कर दीजिए. So epilepsy. See, if you have a question, let us discuss in a very brief format. Pediatric epilepsies. There are 3 pediatric epilepsies which are relevant, which are important to you. These pediatric epilepsies, first of all, can be divided into based upon the onset. So first of all, we have categories where the onset occurs less than. अब ये जो flowchart I am making, this is a flowchart you will not find in many resources, but it will solve many of your queries and MCQs. So first is onset less than 1 year of age. And second will be those epilepsies where the onset is happening at or beyond 1 year of age. So onset before 1 year of age and onset at or beyond 1 year of age, right? Now, those with onset less than 1 year of age can have 2 possibilities. So they can have 2 possibilities. First, those which are having a good prognosis and those which are having a poor prognosis. We are not talking about seizures. We are talking about epilepsy. I hope you know the difference between them. Seizure is a one-time acute event. If recurrent seizure occur, then we call it as epilepsy. So pediatric epilepsy onset less than 1 year with good prognosis includes conditions like benign neonatal convulsions. There is a second category called as benign familial neonatal convulsions. दोनों के अंदर there are defects which are self-limited and newborns tend to have seizures, but as the age increases, the patient tends to come out of it. Poor prognosis will be seen in a patient who's having infantile spasm, also called as West syndrome. Now the term West syndrome is preferred in them. The onset in these children is always in infancy. These children are always having low IQ and they are having a type of seizures called as salam spell, also called as salam attack, where there is a jerky movement of head and neck and limbs upon the trunk. And when you do EEG in these patients, you will find a pattern known as 𝗗𝗄𝗧. 𝗗𝗗𝗧 is a type of chaotic polyspike pattern which is suggestive of West syndrome. What is the drug of choice in these patients? It is always high dose ACTH. If that is not in the option, the second best answer will be 𝗬𝗵𝗿. On the other hand, if MCQ is saying drug of choice in West syndrome due to tuberous sclerosis. Tuberous sclerosis is a type of neurocutaneous syndrome. In such patients, the drug of choice will always be 𝗬𝗵𝗿. The drug of choice in such patients will be 𝗬𝗵𝗿, right? On the other hand, pediatric epilepsy with onset equal to or more than 1 year. There are some possibilities you would consider. First possibility, if the MCQ says epilepsy more common in female than male, there is brief, vacant, staring look. There is a decline in scholastic performance and the patient is having EEG showing 3 Hz spike and slow wave pattern. 3 Hz spike and slow wave pattern. What is the likely diagnosis? The patient is likely suffering from absent seizures, also called as petit mal epilepsy. In these patients, 𝗗𝗘𝗧𝗃𝗧 will be useful. 𝗗𝗘𝗧𝗃𝗧 can be useful, or valproate can be tried. वो दोनों नहीं पूछेगा examiner. One out of these will be mentioned in the question, and that will be your answer in the question. Then second possibility, if the examiner says female more than males, onset occurring. यहाँ पर onset क्या था? Here the onset will be between 3 to 8 years. Here onset will be 10 to 16 years. And there is a girl who gets up seizures, myoclonic jerks or myoclonic seizures, more in the morning hours, which lead to frequent falling of objects from the hands. These are the patients who are suffering from an epilepsy known as juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, also called as Jan's syndrome. And in these patients, the drug of choice will always be valproate. If someone asks you what is the gene involved, juvenile myoclonic epilepsy, the most common gene involved in the patient is 𝗂𝗏1 gene. 𝗂𝗏1 gene. So look at this flowchart. It is a very simple looking flowchart, but it has a lot of information. It is not only telling you which are the conditions which have an onset less than 1 year and more than 1 year. I have also tried to summarize the key points about these conditions which have been asked, and some of them are likely to be asked in the future exam. Remember, febrile seizure is not considered epilepsy because it is only triggered by fever, and it tends to improve without therapy after 5 to 6 years of age. So febrile seizure is not epilepsy. Right? Remember this funda. Now the next query I'm going to take up. Lot of you have been asking, ki sir, okay, 𝗏𝗏 Vinay has asked a one-liner question. If the question says which is the least teratogenic virus, what should we pick up, HSV or parvovirus? 𝗏𝗏 Vinay, remember that both of them are considered non-teratogenic, but parvovirus B19 has no teratogenicity. Herpes simplex virus is written as less to minimal teratogenic. So if you have to choose one, you know the answer. Which is the better answer? Parvovirus B19 will be the better answer. Moving further, question is asking diabetic ketoacidosis के बारे में सर बता दो. Okay, many of you have asked. See, diabetic ketoacidosis is a huge topic. 3 or 4 points I want to emphasize here. First of all, DKA, diabetic ketoacidosis. Full form क्या है? Diabetic ketoacidosis. And if you look at the MCQs, MCQs are asked not from medicine, but from pediatric diabetic ketoacidosis. Although the rules I'm going to say will be applicable in adult also. Diabetic ketoacidosis has 3 components. First of all, diabetes. Second is ketosis. And third is acidosis. What is diabetes? First of all, what are the criteria to define diabetic ketoacidosis? All 3 criteria should be present. Then we say diabetic ketoacidosis is present. So, pehla, patient should be having hyperglycemia. What should be the degree of hyperglycemia to define DKA? It should be more than 250 milligrams per deciliter. Some books say 200, that is also correct. It depends upon which classification you are using. So first is hyperglycemia. Second is there should be presence of ketosis in the patient. Right? What is ketosis? Excess ketone bodies in the body. Ketosis can be in the form of ketonemia. Ketonemia means ketone bodies are circulating in the blood. Or there will be ketonuria. Either of the two can be present. Which is more sensitive? Ketonemia is more sensitive. And they can ask you in exam, when you check for ketonemia, blood में कौन सी ketone body, which ketone body do you check for? Serum beta hydroxybutyrate. Beta hydroxybutyrate, also written as BOHB. This is the most sensitive antibody, which is the most sensitive ketone body, whose presence indicates presence of ketosis. If you are checking in urine, that is less sensitive, but there should be 2+ or 3+ ketone bodies in urine. That is important. 1+ can occur even in non-ketoacidosis patients also. And third feature will be acidosis. What is acidosis? Metabolic acidosis should be present. What is the criteria to define metabolic acidosis? According to Ames protocol, if the venous blood pH, it is not the arterial blood, remember this, a key funda. ABG नहीं करते हैं, BBG करते हैं यहाँ पर. So venous blood pH less than 7.35 or serum bicarbonate less than, equal to or less than 15 millimoles per liter. If any of the two is present, we say metabolic acidosis is present. तो आपसे एग्जाम में क्वेश्चन आ सकता है. सबसे पहले सिंपल, what is the triad of diabetic ketoacidosis? Triad is hyperglycemia, ketosis, and metabolic acidosis, right? How do you define hyperglycemia? We have discussed. How do you define ketosis? Either ketone bodies in blood, which is more sensitive. Which ketone body? Beta hydroxybutyrate or ketonuria. Kitna ketonuria? 2+ or 3+. Why is ketonuria less sensitive? Because beta hydroxybutyrate is not excreted in urine. It is the acetone and acetoacetate which are excreted into urine. और तीसरा metabolic acidosis, this is the criteria. So पहले तो diabetic ketoacidosis define करेंगे. Second point, where it is more common? DKA is more common in type 1 diabetes mellitus than type 2 diabetes mellitus. It can occur in type 2 also, but less common. It is precipitated by stress. What kind of stress? Emotional stress nahi, physical stress like infections, trauma, surgery, or sudden reduction in the insulin dose. If it is an already known patient, there is a sudden reduction in insulin dose that can trigger diabetic ketoacidosis in the patient. And about 20 to 40% cases are newly diagnosed type 1 diabetes mellitus. So you need to understand कि बच्चों में क्या problem है. Parents sometimes do not know their child is having diabetes. And when the child develops DKA and he presents to emergency, then only they realize the patient is having DKA. So सबसे पहले, how are you going to make the, how you are going to do the management? So सबसे पहले, you will have to remember the clinical suspicion in the patient. Clinical suspicion will be there. Clinical suspicion will be there if the patient is having polyuria, polydipsia, nausea, vomiting, abdominal pain, so acute abdomen-like manifestation. Along with that, patient presents with Kussmaul's breathing. I hope you know what is Kussmaul's breathing. Rapid deep respiration is called as Kussmaul's breathing. क्या होता है patients में? There is metabolic acidosis, which causes compensatory respiratory alkalosis. And because of that, there is stimulation of respiratory center, producing hyperacidotic breathing in the child. We call it as Kussmaul breathing. And many times there will be altered sensorium as well. Some patients present in coma, more commonly they present with lethargy, irritability, and depressed sensorium rather than being completely unconscious. So these are the manifestations which can happen in the patient. Now the patient presents to you how you are going to do the management. Whenever a patient of diabetic ketoacidosis presents, first of all, ABC should be done. What is ABC? Airway, breathing, circulation. You will ensure you will obtain IV access. And then you will send the blood investigations. You will send the blood investigation, and simultaneously you will start with the definite therapy. When you start with definite therapy, remember that in the management of diabetic ketoacidosis, the first step is always fluid management. Yaad kar lo, where if it is shock patient, first thing is fluid management. If it is diabetic ketoacidosis, first step is fluid management in the patient. Just a minute, please. I'm getting a call repeatedly. Just a minute. Am I audible and visible? Please confirm. Am I audible and visible? Am I audible and visible? Please confirm so we can continue. Yes, no, and I will start. Just say a yes or no and I will start. Okay. Okay. Thank you. Thank you. So first step. So abhi tak, the flow got broken. I will say again. So management of diabetic ketoacidosis. Patient comes to you. First thing to do is airway breathing circulation. Obtain IV access. एक investigation भेजेंगे. You will send the investigation markers, culture, etc. साथ में you will start with definite therapy. Now, first step in the management of diabetic ketoacidosis is always fluid management, because many of these patients are having dehydration. And the cause of death in these patients is fluid disturbance, which causes brain edema. So cerebral edema is the cause of death. Somebody asked me, sir, most common cause of death in DKA. So I'm writing on the side, the cause of death in DKA is generally cerebral edema. So you can add it to your notes also. It is a major cause of morbidity and mortality in diabetic ketoacidosis patient. So first step क्या करेंगे? Fluid management, because these patients are having dehydration. What fluid will you prefer? So in the first hour, Allah the Vinay, I'm coming to that. I'm coming to that. Just let me write first of all, right? और ये जो आपने ऑप्शन लिखे हैं, ये सारे के सारी ऑप्शन गलत हैं, अलादी विनय. These options were not there in the question because none of these fluids is used in children. I'm writing down, so listen to what I'm writing. So first hour of admission, you will be starting with normal saline in the patient. Normal saline needs to be given. The question arises, how much normal saline you will give. If it is mild to moderate DKA, diabetic ketoacidosis, in these patients, what is mild to moderate DKA? Where the pH is 7.1 and above, and serum bicarbonate is 10 and above, right? There is a categorization, mild, moderate, severe. उसको याद ideally करना चाहिए, but because it is a doubt solving session, so I'm keeping it simple. So severe DKA is pH less than 7.1 and bicarbonate less than 10. So mild to moderate क्या होगा? DKA there, but pH is 7.1 and above and bicarbonate is 10 and above. In such patients, you will give 10 ml per kg normal saline over IV, obviously, IV over 30 minutes, over 30 to 60 minutes, right? If the question says the patient is having severe DKA, in such patients, the amount of fluid to use will be 20 ml per kg IV normal saline. And this will be given only over 30 minutes. So yaad kar lo, mild to moderate DKA 10 ml per kg, severe DKA 20 ml per kg. And Aladi Vinay, I don't know which source you are using. It is a INI-CET question in which the options did not have all the 4 options में 5D वाला नहीं था, because ये use ही नहीं करते हैं. Try to understand. डायबिटीज का पेशेंट है, पहले घंटे में इफ यू गिव अ डेक्सट्रोज कंटेनिंग फ्लूइड, what is going to happen to blood glucose? Understood? So whatever source you are using, that is not a appropriate source. Okay, this was not the correct option. So mild to moderate DKA, normal saline itna amount exactly precisely yaad rakhna hai. In case the patient presents to you in shock in DKA, shock in DKA is rare. In such patients, you will give 20 ml per kg IV bolus. And how many boluses can be given? Up to 3 boluses can be given in the patient. But this is rare and it will not be asked to you in the exam. Mild to moderate and severe DKA is what you are going to remember. After first hour, 1 hour later of this fluid management, you will do two things. First of all, you will start with maintenance fluid in the patient. How much maintenance fluid will be needed? Daily maintenance fluid. Daily maintenance fluid को calculate करने का, there is a formula known as Holiday-Segar method. Plus, you will add 70 ml per kg fluid. Bracket, you would write 7% dehydration is suspected in patient of DKA. And that will be given to the patient. What is the fluid to be started? 4 to 6 hours. You will use ringer lactate or N/2 saline. N/2 saline means 0.45% normal saline. ये सुनते हुए you must be realizing that this is a topic which cannot be properly done or understood in a online class or in a doubt solving class. But I am trying my best to simplify and tell you what you need to know if you get a question like this. And once blood glucose becomes less than 300, then you will replace the fluid. The fluid is changed to N/2 in 5% dextrose. Right? This is what you will need to do. At the same time, after 1 hour of fluid, you will start with insulin therapy in the patient. Never start insulin in the patient. So insulin therapy, remember the point, never give bolus insulin. Never give bolus insulin. In the 𝗗𝗍 question which had been asked, 2 options had insulin bolus mentioned in it, and you could easily rule out both the options, right? Which insulin is given? Regular insulin is given. And what is the rate of giving regular insulin? It will be 0.05 to 0.1 unit per kg per hour. 0.1 unit, 0.5 to 0.1 unit per kg per hour. You will start the therapy, monitor, and then taper and shift to subcutaneous insulin. Shift to subcutaneous insulin. These maintenance fluids need to be given for how much time? They are given over 24 to 48 hours. देखो सारी doses नहीं याद करनी, but इसके ऊपर MCQ आया नहीं CT में, so we are forced to discuss doses here. Otherwise, pediatric में not every dose needs to be done for the exam. And third thing, correct hypokalemia, which is if present, there is no need to correct hypophosphatemia because phosphatemia tends to autocorrect itself. There is no need to correct hypophosphatemia in the patient. ये है जो आपने याद करना है. And the 𝗗𝗍 MCQ which had been asked, they had asked this particular therapy in the exam. This particular thing they had asked in the exam. So this is what has been asked for you in the 𝗗𝗍 exam. So add it to the notes. Right? Alladi Vinay, I am talking about DKA. Right? I am talking about diabetic ketoacidosis. अच्छा Alladi Vinay, you are हम DK का बात कर रहे हैं and you are mentioning a separate question into this regarding the fluid of choice for children. ये अलग चीज है. When they say fluid of choice in children, then we go for, देखो, funda is very simple. There should be sodium, there should be chloride, and there should be dextrose in it. Never use DNS in the child, and never use pure normal saline in the child. So in case the question says a normal child who is hospitalized and you need to start maintenance fluids, which fluid is to be started? The best fluid that can be started in the patient is N/4 in 5% dextrose. But the problem is this is not available in India in most places. So what is the second best fluid to be started? It is N/2 in 5% dextrose. So based upon what option has been given to you, this is what you will be remembering. On the other hand, if they say there is a shock in a child or there is severe dehydration in a child, In such a child, you will be using either ringer lactate or normal saline. Dextrose containing fluids are avoided. Third funda, if the question says shock in a SAM child, what is a SAM child? 𝗂𝗍𝗧 or marasmic child. In these patients, a ringer lactate in 5% dextrose will be the favored fluid to be used in the patient. Right? I hope now your doubts have been settled. Next, neonatal. Rahul Saha is saying neonatal jaundice, please. Okay, neonatal jaundice. Next doubt, neonatal jaundice. How to manage? The question they will ask will be related to a term baby. So remember the funda that on one side you would write the age of the baby. Other side you would write minimum total serum bilirubin. TSB stands for total serum bilirubin to start phototherapy. If age of the baby is 24 hours of life and the total serum bilirubin, TSB stands for total serum bilirubin, it will be equal to or more than 10 milligram per deciliter. Aladi Vinay, I hope your doubt is cleared, right? If the question is 48 hours of life, minimum TSB to start phototherapy is equal to more than 13. 72 hours of life, it is equal to more than 15. And if the question says 96 hours and beyond, the minimum TSB to start phototherapy is equal to or more than 18 milligram per deciliter. If total serum bilirubin value is equal to or more than 24 to 25, or there is any evidence of encephalopathy in the patient, then you will consider DVET. What is DVET? Double volume exchange transfusion. Double volume exchange transfusion. This is a summary. And if you have solved the previous question, NEET PG 2020, there was an MCQ asked on this. The question asked was, day 5 child, TSB 14 milligram per deciliter on breastfeeding, what next needs to be done? The answer was observation. Because day 5 means 96 hours and beyond. 18 se upar hoga, so you will start phototherapy. There is no indication for exchange transfusion. So what you will do? Observation. Never stop feeding the child. So stopping breastfeeding was another option, which was not the answer. Right? Shivani Chaudhary, there is no easy way to remember milestone. You have to go the hard way. Human tendency to look for shortcuts. There is no shortcut for success and there is no shortcut for milestone. I have already discussed milestone in full details in my videos, as well as in my offline classes, as well as in the revision programs. So please advised to go through them. In case you are running short on time, go through the recent most MCQs and add them to your notes. Also remember that fine motor milestones and cognitive milestones are more frequently asked than other milestones. If you look at the number of questions which have been asked, fine motor and cognitive, more questions have been asked. I saw a doubt where somebody was saying, sir, should we do milestones or should we leave them? Deepak Reddy is asking, sir, how to remember development milestone? Is it better to leave? Deepak Reddy, kya chodoge? You have too many things to leave. If a question is not asked from milestone, you are saved. But if it is asked in the exam, it is a rank decider. So if you are targeting a top exam, top rank, if you want a branch like radio diagnosis, medicine, pediatrics, orthopedics, or dermatology, you have to remember milestone. But if dad has good amount of money and all you are looking is clearing the exam, you means any student, it is not specific, it is for any student, then you can afford to leave out milestones, right? I don't know how it works. If you remember milestone, they may not be asked. If you leave milestone, they get asked in the exam. So keep that in mind. Kernicterus kab hoga? Ojas Gavali is saying kernicterus kab hoga? Kernicterus is chronic bilirubin induced damage to basal ganglia. Kernicterus will happen whenever unconjugated bilirubin will be high and it will cross the blood-brain barrier. There is no absolute value above which kernicterus will always happen. There is no absolute value below which it will not happen. In preterm newborns who are sick, blood-brain barrier gets compromised. even physiological jaundice can cause kernicterus. On the other hand, term baby with no risk factor, they can tolerate jaundice up to 22, 23, 24 and still not develop kernicterus. Okay, next thing. TET spell. What is TET spell? Somebody asked about Epstein's anomaly also. What is Epstein's anomaly? Key points to remember. Epstein's anomaly is a cyanotic congenital heart disease. It is a cyanotic congenital heart disease which is seen when pregnant female takes lithium during pregnancy. If the pregnant female takes lithium during first trimester, what will happen? The basic defect in Epstein's anomaly is atrialization of the right ventricle. इसका मतलब क्या है? Let us understand this in a simplified manner. This discussion will go up on the YouTube. You can watch it again, and key points you can mark and see and understand later also, right? So I am going a bit faster. So atrialization of right ventricle kya hai? Let us look at a normal heart of a person. This is right atrium. This is tricuspid valve, and this is right ventricle inhibition, right? This is what is normally happening. But in Epstein's anomaly, what happens is the right atrium becomes massively enlarged like this. The tricuspid valve is attached below. This is right atrium and there is a small right ventricle. This entire part, which was supposed to become a part of right ventricle, has become a part of right atrium. And this condition is called as atrialization of right ventricle. This produces reduced right ventricle output. This causes decreased pulmonary artery blood flow. And this causes cyanosis in the patient. Although cyanosis is multifactorial, but this is a major reason. When you do chest X-ray in the patient, you will find a box-shaped heart. About 25% patients are also found to have a syndrome known as 𝗵𝗵𝗶 syndrome. 𝗵𝗵𝗶 syndrome is 𝗂𝗵-Parkinson-White syndrome. It's an old AIMS MCQ. Which congenital heart disease has a particular high risk of developing Wolff-Parkinson-White syndrome and arrhythmias? It is Epstein's anomaly. What is the therapy to be given? As soon as the child is born, the child goes into severe cyanosis. So first, it is a ductus-dependent lesion. So start prostaglandin E1 to open the ductus arteriosus and then do emergency surgery. This is the therapy to be done in a patient of Epstein's anomaly, right? Ayush is saying oxygen supply in neonatal children. Ayush, it is a very, very general thing you are asking. What oxygen supply? Oxygen supply there are different conditions have different requirements. Then you need to know the SpO2 values. Then you need to remember the flow rates. Flow rate is something that I do not do. That is something that anesthesia people do. Most of the recent questions are anesthesia questions, not pediatric questions related to newborns, if you're talking about the INICT questions. Next question. Somebody asked about TET spell. Also asked about hypercyanotic spell. Hypercyanotic spell. 𝗂𝗂 is asking what are the updates. 𝗂𝗂, many updates have been asked, but I don't know whether they are relevant for your exams or not. Pediatrics is a very dynamic subject. Remember, PSM, Pharma, Pediatrics, maximum updates happen. Anatomy आज भी वही है, right? Physiology आज भी वही है. So no update comes. But these are the three areas from where a lot of updates are asked in this. So TET spell क्या होता है? It is a complication of tetralogy of Fallot. TET spell क्या होता है? Let us try to understand what is TET spell. It is characterized by a triad of three things. There is worsening of the cyanosis. There is hyperventilation. And there is a murmur heard in a TOF patient called as pulmonary ejection systolic murmur that tends to disappear. So disappearance of pulmonary ejection systolic murmur. Disappearance of the pulmonary ejection systolic. If all the three are present, we say TET-spell is present. So TET-spell hota kyun? Try to understand. There is a vicious cycle of TET-spell that you need to know. What is a vicious cycle? See, what happens is there is a child with already existing tetralogy of Fallot, right? So kya hoga? There will be stress, anger, infection, or dehydration in the child. That will cause excess crying in the child. This crying will cause hyperventilation. Hyperventilation will lead to increase in the right to left shunt. Increase in the right to left shunt will cause further cyanosis. This will cause acidosis. Acidosis will further cause hyperventilation and the patient will get stuck up. Increased right to left shunt can also be caused by any event which worsens the subpulmonary stenosis. Right? So this is called as the vicious cycle. And that is why when you want to treat the patient, you give morphine. Morphine kya karta hai? It abolishes hyperventilation. You give propranolol to the patient. What does propranolol do? It relieves the subpulmonary stenosis. You put the child in knee chest position, also called as squatting position. That decreases right to left shunt. And if still patient is not improving, you will admit the patient and give selective arterial vasoconstrictors, which will raise the LV pressure and oppose right to left shunt. So this is TET-spell, and this is why the drugs which are used are going to be effective there. Then Tarun Agarwal is asking anemia in children. Anemia in children ka ek table hai yaar, already discussed hai. So you can open my QRP session. It is discussed there also. And in my first 5 minutes of the video on DocTutorials app, there also I have discussed criteria to define, WHO criteria to define HB in children. Next, और क्या चीजें क्वेश्चन पूछे गए हैं? Nana Pot is asking vaso-occlusive crisis and osteomyelitis. So, vaso-occlusive crisis and osteomyelitis. Vaso-occlusive crisis is triggered by dehydration in sickle cell anemia. Osteomyelitis has no correlation with dehydration. Second, vaso-occlusive crisis will show no fever in the patient, whereas osteomyelitis will have fever present along with the bone pain. Then, if you do a bone scan will show a cold spot, whereas bone scan will show a hot spot in patient of osteomyelitis. And then, obviously, radiological investigations will be useful to differentiate between the two. Here, treatment will require analgesia along with hydration, whereas here, treatment will require analgesia along with IV antibiotics, and many times surgery can be considered in the patient. So surgical drainage may also be needed in the patient. यशवंत रेड्डी COVID-19 mother breastfeeding guidelines. तो guideline है भाई, detail guideline पढ़ना पड़ेगा. Somebody is asking HIV का भी किसी ने पूछा था. TNA PCR testing, 𝗬𝗎 again detailed guideline है, but remember कर लो. HIV mother bears a child. The baby is labeled as, the baby is called as HIV exposed, right? So question aa sakta hai, what is an HIV exposed infant? Any baby born to HIV positive mother is called as a HIV exposed infant. In such child, first of all, what feeding will you start? The child should be started on exclusive breastfeeding is the preferred mode. If not possible, replacement feed can be given, but mixed feeds should be avoided. Second, you will start with antiretroviral prophylaxis in all children, starting from day 1 of life. If it is all babies are considered to be low risk and you will be starting them on oral 𝗻𝗻𝗯, which is given daily for 6 weeks. If it is a high risk infant, high risk for getting infection, for example, mother not taking ART, mother is HIV positive but not taking ART, you will use combination therapy, oral 𝗻𝗻𝗯 along with 𝗔𝗀𝗻𝗀𝗃 in the patient. And this combination will be given for 12 weeks if breastfed and 6 weeks if formula milk, that is replacement feed given. So MCQ will give you case scenario and there you will decide the duration. In case of low risk infants, the duration will be 6 weeks and it will be monotherapy which will be indicated. And third will be testing of HIV, testing in infants. The method used in these children is dried blood spot. We call it as DBS method. DBS stands for dried blood spot method in the child. Dried blood spot. What is the test to be done? The test is PCR. PCR में क्या check करते हैं? These days we do TNA. What is TNA? Total nucleic acid. That is DNA और RNA दोनों check करते हैं. If that is not available, then you can go for DNA PCR. But अगर दोनों option में है, what is the preferred option? Preferred answer, PCR for total nucleic acid is the preferred thing that you will do. And what is the time of doing testing? You will do around 6 weeks of age. Question arises, ELISA कब कर सकते हैं? ELISA is possible only after 18 months of age. तो 18 months से पहले अगर आपने HIV चेक करना है, it is always done by PCR study. Total nucleic acid PCR study is performed in the patient. राहुल साहब, मेडिसिन फोकस रैपिड रिवीजन वीडियो कब आएगा? बहुत जल्दी आएगा और एक साथ 2-3 वीडियोस आएंगे. आई एम जस्ट नॉट गेटिंग टाइम टू इवन ब्रीथ राइट नाउ. यू कैन सी I had to start the session and I could not get time to even go to my study room and take the session. I'm taking right now sitting in one of the rooms at my home. In kernicterus, do we have exaggerated moros or absent moro? Moro, absent moro. Okay, moro abnormalities. Moro abnormalities. If the question says exaggerated moro, the better answer will be hypoglycemia. Rarely it can occur in kernicterus, right? Absent moro has been described in 2 conditions: hypoxic ischemic encephalopathy stage 3, and second, kernicterus patients with bilateral basal ganglia damage. याद कर लो, ऐड कर. And this is the thing which you need to remember. Okay. Sepsis. Neonatal sepsis. Update I am talking about. Neonatal sepsis. Neonatal sepsis. World or overall, most common is group B streptococcus, also called as Streptococcus agalactiae, followed by Klebsiella. If the question says India, it is now 2024 update. Acinetobacter, followed by Klebsiella, followed by Staph aureus, followed by E. coli. And Streptococcus is not there in the India. This is an 2024 update. Please add it to your notes. Add it to your notes. Okay. Ninjas, I could not understand your question. Surya Kumar is asking recent advances in pediatrics. Yeah, recent advances to bahut sare hain, but the question is, do we need them? It is not needed. Also, if MCQ says drug of choice in PDA, closure. एम्स प्रोटोकॉल का नया एडिशन आया 2024 का, बहुत क्लियरली कह रहा है इंडोमेथासिन, sorry, ibuprofen, really sorry, ibuprofen followed by indomethacin. And paracetamol can be used but not routinely recommended. यूज कर सकते हैं but it is not a favored agent in the closure of PDA in children. What else? कोविड पे क्वेश्चन आने बंद हो गए हैं वैसे भी. Congenital syphilis. Congenital syphilis is of two types, early and late. What is early? If the onset of sign and symptom occurs less than 2 years of age, we call it as early. And if the onset of sign and symptom happens at or beyond 2 years of age, we call it as late syphilis. There are separate features of early syphilis that you need to know, separate features of late syphilis that you need to remember. Okay, what else? Which hormone is responsible for height development in female? Ninjas, remember that androgens are more important for gaining of height rather than estrogen. But because the androgen levels and strong androgens are more common in males, and that is why males tend to have a longer height. The males tend to be taller compared to females. But it is a very crude question. It will all depend upon how the question has been framed. And actual height depends upon genetic potential, lean body mass, as well as upon the growth hormone and IGF-1 levels, not the androgen. Androgens have a facilitatory role, not the predominant role. नहीं तो सब लोग एंड्रोजन ले और हाइट लंबा हो जाए. Okay, rickets treatment protocol, please summarize. Okay, rickets treatment. Old regimen is called as the Stoss regimen. Stoss regimen में what we used to do, either single dose 6 lakh international unit once or 60,000 international unit per day for 10 days of vitamin D3 was given to the patient, plus oral calcium was given to the patient. Right? What is the new regimen? The new regimen says daily oral vitamin D3 given for 12 weeks is the therapy of choice, plus oral calcium dose. What is the dose? If it is an infant, the dose will be 2,000 international unit per day. And if it is an older child, the dose will be 3,000 to 6,000 international unit per day. Right? याद कर लो. मुश्किल नहीं है, but you need to remember the values separate. Somebody is asking investigation of choice for Hirschsprung disease. Investigation of choice for Hirschsprung disease. Hirschsprung disease की बात कर रहा हूँ, Hodgkin lymphoma नहीं है ये. Hirschsprung disease. It is always, what is it? Obviously, rectal biopsy, bhai. Investigation of choice is always rectal biopsy. Failure to see ganglion cells and hypertrophy of nerve root fibers, nerve trunk fibers is diagnostic of Hirschsprung disease in the patient. You can always do anemas, but they are never the investigation of choice. Clinical features of different types of refractory rickets. Ninjas is asking, okay, a refractory rickets. एक होता है nutritional rickets, right? Nutritional rickets. Nutritional rickets is one which vitamin D deficiency से होता है, and the usual features that you see. Refractory rickets. If question says patient is having refractory rickets को मैं RR लिख रहा हूँ, बार बार पूरा नहीं लिखूंगा. Refractory rickets, patient is having a raised urea and creatinine. The patient is having acidosis. Patient is having low GFR. You will think of renal cause, renal osteodystrophy, now called as CKD, MBD. CKD means chronic kidney disease, MBD means mineral bone disease. This is the new name. Harrison भी यही कहता है, Nelson भी यही कहता है, of renal osteodystrophy. If the question says the patient is having refractory rickets, normal anion gap, metabolic acidosis, if the patient is likely to have RTA. RTA is not road traffic accident. This is renal tubular acidosis. If the question says refractory rickets, autosomal recessive inheritance, patient is having low 125 DHCC levels, you will think of VDDR type 1, vitamin D dependent rickets type 1. If the question says high 125 DHCC levels along with alopecia and epidermal cysts, you will think of VDDR type 2. Both are severe forms of rickets and VDD genetic forms of rickets. And lastly, if the question is saying refractory rickets, dental abscess, lower limb deformities, and X-linked dominant inheritance, you will think of X-linked hypophosphatemic rickets. So these are the clues for the underlying diagnosis. Look at the keywords and you will reach the correct answer if you get a question like this in the exam. Yashwant Reddy, gold standard is also the same. In many conditions like cystic fibrosis, like Hirschsprung disease, investigation of choice and gold standard are same. आपने neonate में treatment of choice caffeine है या थियोफाइलिन? Caffeine is preferred over thiophanate. Tarun, it is always preferred. Safe and more effective. Caffeine is preferred. Nobody uses thiophanate. Right. I think it is time now for me to finish off the session. So, Aladi Vinay, see, there are topics like GINA guidelines, CE guidelines, and similar guidelines. In case any of you is finding any difficulty in finding where to read them, and please drop me a message. You can put it in the comments also, or you can put a message to me in Instagram also. Let me see if I have the Instagram. Yes, this is the link. थोड़ा सा फिल्टर लगाया बट इतना फिल्टर नहीं लगाया, पहचान में आ जाऊंगा. संदीप शर्मा 108, Dr_Sandeep Sharma_108. It's a verified profile and you can scan this thing also and message me there, and in case I can be of any help close to your exam. But don't try to read exotic stuff. Important things, multiple revisions is more important. Aladi Vinay has asked, in CAH workup in an antenatal female, why do we stop giving cortisol if the fetus is male? Aladi Vinay, because the chances of virilization in male are minimal. When you give in female, you need to continue it because throughout the intrauterine life, there is a risk of virilization or ambiguous genitalia occurrence in the female. In case it is a male child, the risk of in utero virilization is less if initially cortisol has been provided. And that is why throughout the pregnancy, if it is a male infant, we do not need to give cortisol. No, no. Ninjas, that is not true. CAH can occur in males also, it can occur in females also. But the degree of virilization and sensitivity, the tendency to develop virilization in utero is more in female. And that is why we are giving, to prevent virilization, we are giving in utero steroids to the pregnant lady. Okay. I think most of the doubts I have covered, except for 2 or 3 things which obviously cannot be discussed in a live session like this. So all the very best, students. Do not give up. And in case I can be of any help to you, please message me and I will try to share. And don't think कि sir को भी message किया immediately sir कर देंगे. But I will try to get back to you. Right. So all the very best and take care. God bless everyone. Don't miss out on the other YouTube sessions also of excellent faculties who will be coming from DocTutorials. So watch out. Thank you so much. कॉन्टैक्ट नंबर यार स्पैम नहीं करना है, वो यूट्यूब पे नहीं दूंगा. मैसेज कर देना मुझे, उसमें दे दूंगा. यूट्यूब पे नहीं, ये यूट्यूब पे जाएगा. तरुण अग्रवाल, नीट यूजी में जितना कट ऑफ गया नीट पीजी में नहीं होगा. नीट पीजी एग्जामिनर्स आर स्मार्टर देन नीट यूजी एग्जामिनर्स. Trust me. In fact, NEET PG examiners are better than people making INI-CET also. NEET PG is a better, more clinical, more quality paper than INI-CET. AIMS people will be offended with me. A couple of them are my seniors also, like super seniors who are now consultant. I know it's okay. जो fact है वो fact है. NEET PG better paper, better quality paper than INI-CET. Remember that. Bye bye.